Semua ada dah?
Semua ada dah, doktor.
Semua
dah ada.
Berapa orang?
24.
Tak nampak muka ke? Nur Aiza mana muka?
Tak doktor, tu laptop saya guna phone sekarang. Yang tu laptop saya guna dua device. Ni saya. Saya ada dua device kat sini.
Afika mana? Syuhib. Mana muka you all? Syuhib dua device juga? Syuhib, you pakai dua device juga? Syuhib?
Tak guna.
Dua nama dia? Nur Aiza, you pakai dua device ya?
Yes, doktor.
Nur Aiza. Okay. Siapa start kau? Okay.
Okay. Assalamualaikum. So welcome to today's case-based learning seminar. So today we will be discussing about 4 topics: child with altered sensorium, child with abnormal gait, lower limb weakness, and also diarrhea. So the first presenter would be me. My name is Nur Aiza Minti Zaidi, and I will be presenting about the child with altered sensorium. So this is an example of shift complaint that patient may present with. The 7-year-old previously healthy girl was brought to the emergency department with increased sleepiness for 1 day duration. Okay, so altered sensorium can be defined as a spectrum of disorders that includes clouding of consciousness, confusion, obtundation, stupor, and also coma. In young children, it may manifest as fussiness or irritability. Or it can be categorized by failure to respond to verbal or physical stimulation in a manner appropriate to the child's developmental level. Okay. So as per mentioned, altered sensorium or altered mental status is a spectrum of disease which can be described as shown. So clouding of consciousness can include a mild form of altered level of consciousness which when there is inattention, decreased alertness, and reduced wakefulness. And confusion involves a state of disorientation along with bewilderment and difficulty following commands. Obtundation is slow response to stimulation and decreased periods of time spent in wakefulness. Stupor refers to a mental state when patient can only be aroused by repeated and vigorous stimuli. Meanwhile, coma is a persistent state of unresponsiveness despite attempts of arousal. So for the differential diagnosis, we can use the mnemonic of AEIOU tips, which is, so the A can be described as alcohol or acid-base and metabolic disorders. And then for the E, it can describe the encephalopathy or endocrinopathy such as Addison disease or thyrotoxicosis, and also electrolyte imbalance. And for the I, insulin. So in severe DKA patients, they may present with altered mental status due to the hyperglycemia. And then in as well in patient with hypoglycemia when the blood glucose level is less than about 2.2 millimole per liter. And then intussusception, which may also be presented with altered mental status or altered sensorium. And then is there any ingestion of opioids or any disorder that can cause hypoxemia or hypercapnia? And then uremia, such as hemolytic uremic syndrome. And then if there is any history of trauma or underlying tumor, causes, especially the infection, meningitis or encephalitis, or is there any intracerebral vascular disorder which can cause hematoma? And then is there any underlying psychiatric illness or psychogenic, or any ingestion of poison? And lastly is seizure. And differential diagnosis can also be divided based on the common cause according to each group. So this table. Okay, so for history taking, it is important that we need to always remember the questions that we want to ask, such as what, when, where, and how does this happen? So we can ask about the prodromal events before the change in the consciousness level. So we can ask about whether it is acute or insidious, the duration, is there any recent illnesses or infectious exposure, or is there any recent trauma? And then for the risk factors, we can ask about underlying medical illness, such as previous history of seizure, traumatic brain injury, or any psychiatric disorder. So assess the developmental milestone, is there any delay? And then vaccination history. And then look for dietary history in infant, which may suggest hypoglycemia. And then family history, such as family history with similar symptoms or with history of seizure previously. And then possibility of toxic ingestion or exposure. And then ask for the associated symptoms such as fever or weight loss, vomiting, diarrhea or abdominal pain, and then headache, abnormal gait, seizure and seizure activity or weakness, which may suggest any CNS causes. And then also note that when we took the history, we can look for the way the parents answered the questions. If the answer is not consistent with the physical findings or any delay in answering, we should also suspect any possible cause of child abuse. Okay. Next, for physical examination. Okay. Next, for physical examination, we inspect for the appearance, is the patient is toxic looking, or is there any rashes. Look for the shape of the head, is it abnormal, is there any bulging fontanelle, hemorrhage or bruises. And then look for the eyes, is there any sun-setting eyes as shown in the first picture, which may indicate increased ICP, any raccoon eyes, retinal hemorrhage, and also we need to look for the vital signs as well. And then look for any signs of increased intracranial pressure, as per mentioned. And then not to forget, we need to examine the cardiovascular and also respiratory. So for cardiovascular, patient may present with arrhythmia, for example, in case of toxic ingestion. And then look for the respiratory effort if in case the brainstem is also affected. And then most importantly, the neurological examination, look for any focal findings of asymmetry of the facial, pupils, asymmetry pupil size or reflex, and look for any asymmetry of the motor system as well. And then assess the Kernig and Brzezinski signs for meningitis. And lastly, the Glasgow Coma Scale.
Glasgow Coma Scale for children,
Okay.
Yang ambil adultnya.
So this one, I've put in a table, the
Pediatric,
difference
okay.
between the pediatric and also the adult GCS scoring.
12 years and above, you boleh pakai adultnya. 12 years and above.
12 years
Okay.
and above, okay. All right. So next for the... okay.
Tell us
Okay.
the difference.
All right. So basically, under Glasgow Coma Scale, mainly the main differences are basically in the verbal response, where for example, so they put the scoring into 1 until 5. So the first one is none, cries, vocal sounds, words, and also oriented. So it's slightly different from the adult because adult can definitely respond to verbal or understand what we say, unlike the pediatric patients. And slight difference in the motor response as well, where the scoring is 5 in pediatric, but 6 in adult. Okay. So otherwise, they are more or less the same. All right.
When you find pediatric motor response. Okay. Apa yang tak ada dalam tu? Withdrawal to pain. Ya.
Withdrawal to pain tak ada.
Okay.
Okay. Next, under investigation. So for the bedside, we can perform the capillary blood glucose level to see if there's any hypoglycemia. And then we can also perform ECG if we suspect, if during physical examination, we find any pathologic auscultatory findings or rhythm disturbance. And then for the laboratory, we can send for complete blood count to assess the white cell count, renal profile, liver function test, and also coagulation studies. In case if we suspect any metabolic causes, then EBG if patient is in respiratory distress or any trauma previously, and then blood and urine culture if we suspect serious bacterial infection, and also TFT if we suspect any teratoxicosis may occur. For radiographic, it's very dependent on the clinical findings. So X-ray we might do in case if we suspect any trauma, and then CT scan we can use CT scan in intracranial lesion, or if patient presented with focal neurological findings. And for CT angiography, if we suspect any vascular injury, and then abdominal ultrasound, it may be useful in if we suspect any intussusception, okay, or to assess acute ingestion of radio-opaque material. Okay, and then any additional tests such as toxicology if we suspect any drugs ingestion, or lumbar puncture if we suspect meningitis for CSF analysis. But we need to correct the shock, hypotension, and also hypoxia before we perform the lumbar puncture. So for the management, so when patient presented with altered sensorium, we need to assess the airway breathing circulation first before we actually proceed with history and also other things. So assess the airway, secure the airway if needed, consider for intubation, and then the breathing, look for, assess the SpO2 and also ventilation if required. Circulation, we can use IV bolus or inotropes or do chest compression. And then dextrose, we correct the hypoglycemia if present. So once a patient is stabilized, we monitor the vital signs and also SpO2 and also the urine output. So GCS, if the GCS at initial presentation is 12 and above, we can monitor the GCS hourly. And if it's less than 12, we monitor the GCS half an hour until they improve. So these are the considerations for intubation that we may consider. So the first one, if the airway is obstructed, if not supported, if the airway is compromised by vomiting, if the respiratory rate is too low for adequate ventilation, if the SpO2 remains less than 92% despite high flow oxygen, and if there are any signs of shock, even after fluid resuscitation, signs of exhaustion, and also GCS less than 8 and deteriorating. And then we need to look and treat accordingly based on the underlying causes. So we need to treat the sepsis, shock, and seizure first. And then if there is any presence of raised ICP, we need to nurse the patient properly, such as the positioning of the head, slightly elevated about 15 to 30 degrees, and also avoid unnecessary procedures such as suction and so on. And then ventilation, we maintain the ventilation, and then we'll look for the fluid and electrolyte imbalance and monitor them. And then maintain the cerebral blood flow. We keep the cerebral perfusion pressure about more than 50 millimeter mercury. And then we can consider IV monitor or hypertonic saline. And we can administer antibiotics if we suspected meningitis as well. So these are basically the general management for altered sensorium in pediatrics. Otherwise, I think this is my last slides, the references. So that's all from me.
Last kali kita beritahu you have to treat the causes. That's the main issue. You stable the patient, but at the same time you find the causes and treat the causes. If not, you can never you will not able to reverse the change conscious level. Dan yang paling penting you hafal definition tu. Apa conscious level, apa stupor, apa tu you kena hafal, no choice tak ada magic bullet you hafal, because then you bila you tengok patient you kena assess which one to which one. Go different level conscious level, different management dia. Okay, now next one.
Okay.
The 12 over berapa? Total GCS berapa?
15 in adult.
15 adult. Pediatric 14. Pediatric
Kalau
tahun
ikut,
satu.
if we follow the GCS pediatric just now, it's 14.
Okay, next.
Moving on to the next condition. So I'm going to present about, my name is Regina Nabila, matric number 1811-110. We're going to discuss about child with abnormal gait. Next slide. So this is the chief complaint for today's condition. Fadzil, a 10-year-old boy, presents to the clinic with 4 months history of intermittent pain in his left hip with an associated limp. Next slide. So before we want to know the abnormal gait pattern, we have to know first the normal gait pattern in pediatric patient. So as you can see, in a 12-month-old baby, they will have a broad-based gait and a high step and arm outstretch. While for 15 to 18 months old baby, they will have a heel stride gait and also reciprocal arm swing. At the age of 2 years old, they can run and able to change of direction. And then at the age of 8 years old, they will have an adult gait pattern. Next slide.
Sebelah tengok yang sebelah. Yang semula yang tadi. Go back again. Depan lagi lah. Gambar tadi. Okay.
Okay. Now, for abnormal gait pattern, briefly it means unusual walking pattern. Here I divided into 4 types of gait pattern. The first one is antalgic gait, where as you can see there is shortened stand space, where the patient is unwilling to weight bear, usually in condition where there is trauma or juvenile idiopathic arthritis. The next one is circumduction gait, where there is excessive hip abduction as the legs swing forwards, usually in patient with in-leg length discrepancy or hemiplegic cerebral palsy. In spastic gait, there is stiff and the foot is dragging with foot inversion. As you can see from the video, there is the patient have right spastic hemiplegic gait. The next one is ataxic gait, where it is instability with an alternating narrow to wide base gait. Also usually happen in ataxic cerebral palsy. Next slide. The next type of gait is Trendelenburg gait. Okay, it is it happen when there is hip abductor muscle weakness. So while weight bearing on the ipsilateral side, the pelvis will drops on the contralateral side. As you can see from the video, there is inability of the left abductor to maintain the pelvis. So the left side is the affected side. So it can happen in a leg calf prosthesis, slip capital femoral epiphysis, developmental dysplasia of the hip. The next type of gait is toe walking equinus gait. So for this type of gait, it can be normal in pediatric patient up until like 2 years to 3 years of age, because the child is still learning to walk. But then if it persistent beyond 3 years old, it considered abnormal. Usually in condition such as spastic diplegic cerebral palsy. The next one is stepping gait, where as you can see, the entire leg is lifted at the hip to assist with ground clearance in conditions such as spina bifida, Charcot-Marie-Tooth disease. The last one is clumsy gait. There is difficulties in motor coordination, where patient can have frequent falls and difficulty in self-help skills. Also in condition of cerebral palsy or indolent inflammatory arthritis or metabolic disorders. Next slide. So for causes of abnormal gait, I divide it here into a few different systems. So ranging from orthopedic, infectious, rheumatological, neurological, hematological, metabolic, neoplastic, cardiological, and others causes. So I think you can read this slide, but just to mention few common causes are Toddler's fractures, abuse injuries, transient hip synovitis, Pettis disease, subcapital epiphysis. Okay, next slide. Okay, now for history taking, since different range of age can have different differential diagnosis. For toddler and young child, they common differential that you can think of are toddler's fracture or developmental dysplasia of the hip. While for adolescent, usually they can have conditions such as slip capital femoral epiphysis, juvenile rheumatoid arthritis, or osteochondrosis dissecans. While for the onset, there is acute and chronic. So for acute, you can think of traumatic condition or infection such as septic arthritis, while for chronic, think of developmental or neuromuscular problems such as cerebral palsy or developmental dysplasia of the hip. And then history such as painless or painful. So painful, it's usually patient with traumatic kind of injury, or if it involves infection such as septic arthritis, osteomyelitis. Other causes can be malignancy. While painless, it can range from leg length discrepancy, cerebral palsy, and also developmental dysplasia of the hip. Next slide. The next important history is the characteristic of the pain itself, whether it is constant, intermittent, focal pain, burning pain, or gradually worsening pain. Now for constant pain, it can be due to fractures, septic arthritis, and also osteomyelitis. Intermittent pain can be from JIA, Pettis disease, strep capital femoral epiphysis, and also transient synovitis. While for focal pain, can be due to infection, malignancy, or fracture. Burning pain usually caused by nerve involvement. For gradually worsening pain, usually caused by malignancy. Other associated symptoms that we can ask the patient is for infection or malignancy, ask for any other constitutional symptoms such as weight loss, and then night pain, fever and chills, and then the inflammatory or rheumatologic, ask for any regression of motor milestone, any rash, arthralgia, myalgia. For developmental, ask if there is any delay in gross motor milestones, if there's any persistent primitive reflex, and also failure to thrive. For hematological, example in differentials such as hemophilia, okay, you can ask about bruising, bleeding tendency, and also hematemesis, and also referred pain such as abdominal pain. Next slide. Okay. Other history, important history, any exacerbating factors, relieving factors, functional limitation, history of trauma, inconsistent history, and incongruent injuries, such as what Aiza mentioned before. So it can be a high suspicious of child abuse. Other history are past medical history, such as if there is other recent viral infection, antecedent urogenital or GI bacterial infection, or any history of hemophilia. Birth history is also important. In case of prematurity, delivery problems, breech position and oligohydramnios, which is one of the few risk factors for developmental dysplasia of the hip. And then we should take note of developmental history, family history of autoimmune, neuromuscular, hematological, or metabolic disorder, and also the social history to look for overall child's activity. Slide. Okay, moving on to physical examination. So generally, we want to look if the patient is in pain, if patient is pallor, if there is any generalized wasting, skin changes such as rashes, bruises, burn or scratches, and then lymphadenopathy, and also feet for callus and blisters. The next one for anthropometric, also important because we want to know if there is a poor growth, in example in any other chronic disease, vital sign, temperature, heart rate, and also respiratory rate that can indicate if there is any presence of infection. Okay, and then for musculoskeletal examination, so we have to look, feel, and move. So look for any bruising, any swelling or deformity, and then look also the symmetrical of joint appearance. And then feel for warmth, if there is any tenderness, and then pain, palpable bone mass. And then for move, check the joint range movement, okay, hypermobility of the joint, and then other special tests such as Trendelenburg test that can indicate hip pathology. Other examination are neurological examination, where you check the muscle bulk and the symmetrical of the joint, and then check for the tone power reflex, if there is any persistent primitive reflex, example in cerebral palsy, and then special tests such as Gowers test in Duchenne muscular dystrophy. Okay, next slide. Okay, moving on to investigation. So the first baseline investigation that we can do is full blood count to detect the presence of anemia in chronic disease, to rule out other hematological cases and also to look for leukocytosis in case of infection. For peripheral blood film, in case of acute leukemia, so you can see blast cells, and then ESR or CRP, it will be raised in condition such as infection, inflammatory arthritis, or malignancy. Coagulation profile in hemophilia patients, so they will be raised APTT. Blood culture and sensitivity for to detect presence of infection. And then serum calcium and phosphate in conditions such as osteomalacia, where there will be raised of the serum. Next slide. And then anti-streptolysin O titer. So it will be raised in acute rheumatic fever. Okay. And then for osteomyelitis, you can do bone culture. Joint aspiration and synovial fluid culture can be done if you suspect septic arthritis. And then anti-nuclear antibody and anti-dsDNA can be raised in SLE patient. The investigation that can be done is serum CK, ALT, LDH in case of inflammatory muscle disease, and imaging investigation such as X-ray and ultrasound in case of fracture or other bone abnormality, or evidence of soft tissue swelling or effusion. Next slide. Now, for management, I divide it into pharmacological and non-pharmacological. So for pharmacological, the first one is infection. You can give antibiotic such as cloxacillin, which given in septic arthritis. Okay, and then for septic arthritis also, you can do urgent washout and drainage of the infected joint. If in case of inflammatory joint pain, you can give NSAIDs, intra-articular steroid injection, or DMARDs. And then if spastic limb in cerebral palsy, usually we will give anti-spasticity medication or botulinum toxin injection to provide relaxation to the muscles. So the non-pharmacological management would be physiotherapy. We want to improve and maintain range of motion, and we want to strengthen the muscles. The next one is occupational therapy, that we want to improve the quality of life, and some patients might need special equipment such as walker, brace, or orthotic. And then surgery might be needed. So you want to refer them to the pediatric orthopedic surgeon. So what are the surgery that can be done is such a muscle or tendon lengthening, or osteotomy for realignment or reconstruction. And then the last management is we want to treat any underlying medical condition. Okay, that's next slide. Okay, that is for my presentation. These are my reference.
Yang paling penting you recognize the gate. I think the one picture you gambar tu, you tengok berpuluh-puluh kali sampai you really recognize that. You're lucky because you have video now. Zaman dulu kita orang dulu semua tak ada. So banyak imagine. So you all sekarang ni you bertengok ulang dan ulang sampai you recognize. It stuck to your brain. This one, because you recognize, you know what to do next. That if you don't recognize, there are many possibilities atau mana satu. Because the type of the gate can help you to decide what to do next. Okay, next.
Okay. Okay, Assalamualaikum. My name is Umi and I will proceed with the next one, which is child who has lower limb weakness. Okay, next. So this is just an example of how the patient may present. So this is a complaint of an 11-month-old boy presented with weakness of the lower extremities for 1 day and difficulty feeding for 10 days with history of fever and diarrhea 2 weeks prior to the onset of weakness. Okay, next. So weakness is one of the common complaint presented by patient. It is defined as the loss of muscle strength or decreased ability to voluntarily or actively move the muscles. And some patient may use this weakness. I mean, they may complain of weakness even though it's not actually weakness, which means they may have like joint pain or any limitation of the joint motion. Meanwhile, hypotonia is defined as the low muscle resistance to movement, and in which in some of the cases, weakness may be accompanied by the hypotonia. And weakness can be caused by any lesions of the upper motor neuron or the lower motor neuron, neuromuscular junction, skeletal muscle, or systemic disease. Okay, next. There are a lot of causes of limb weakness in children, and therefore it is important to note the ones that are important and common, in which this includes almost all the lesions of the upper motor neuron and the lower motor neuron, including the poliomyelitis, spinal muscular atrophy, Guillain-Barré, myasthenia gravis, stick paralysis, botulism, myositis, as well as Duchenne muscular dystrophy. Next. Okay, as for the history, okay, first we'll explore on the lower limb weakness. We'll need to ask about the onset and duration of the weakness, and then to see to ask if it is symmetrical or asymmetrical. And asymmetrical can be seen in poliomyelitis. And then location of the weakness at onset, it can be proximal or distal or generalized. Generalized is seen in metabolic myopathy, and distal weakness may be caused by peripheral nerve lesion. And then for the weakness, is it ascending or descending? Ascending, which means the weakness starts from the lower part of the body, which move toward the upper part of the body, which start at the lower part and then towards the upper part. And this include ascending usually in Guillain-Barré, and descending, which can be seen in botulism. And then progression and severity and previous episodes of weakness, and then to explore on the worsening and relieving factors, for example, like in myasthenia gravis, where the muscle weakness worsens after periods of activity and repeated use, and it improves after periods of rest. And then to see if there is any associated symptoms like pain, for example, seen in maybe local trauma, and then numbness or vomiting. Vomiting can be due to increase in ICP, and therefore should explore more on the nature of the vomiting. And then for any history of preceding infection, as seen in Guillain-Barré syndrome, which they can present with AGE or URTI prior to the weakness. And then to check for any bladder or bowel incontinence that may suggest of spinal cord injury, be it infection or tumor. And then back pain. Back pain can be due to like compression of the nerve at the spine, in which the patient may present with back pain as well as weakness of the limb. And then bulbar weakness that can be seen in myasthenia gravis, facial paralysis in cases of stroke or brain tumor. And then any oculomotor involvement and respiratory failure, if there is a weakness of the respiratory muscle or if there is any lesion at the respiratory center. Next. Okay, for the other history that are also important, in which it can help to rule out the causes. The first one is any history of ingestion of toxin to rule out toxic myopathy, any ingestion of spoiled canned food, as seen in botulism. And then to ask for the any birth history of preterm delivery or maternal infection, for example, torches, and also to see if there is any delay in the motor milestone, speech or language that is needed to exclude brain pathology. And then any misimmunization, because this is to rule out poliomyelitis, the vaccine of IPV, any vaccination. And then family history of autoimmune disease or hereditary muscular disease like Duchenne muscular dystrophy. Okay, next. Okay, for the physical examination, generally, we have to see if the patient is conscious and alert. And if there is any signs of respiratory distress, later if there is any signs, then we should proceed with respiratory examination. And then any syndromic phases, and also to note the surrounding if there is any presence of walking aids like wheelchair or walking stick. And then we'll proceed to the central nervous examination, CNS examination, which will start with the inspection to see the muscle bulk, if there is any muscle wasting or pseudohypertrophy. Pseudohypertrophy can be seen in Duchenne muscular dystrophy. And then any presence of engorged tick, intics paralysis, and fasciculations that may suggest of lower motor neuron lesion. And then to proceed with the lower limb examination, to look for the TPR, tone power reflex. And the tone may be normal, may be hypo or hypertonia. And then the power that is reduced and reflex. And Babinski reflex, positive Babinski reflex may suggest of upper motor neuron lesion. And then also to test for the sensory, because there is a loss of sensation in a few of the causes, like in GBS as well as acute transverse myelitis. And then cranial nerve examination, if there is presence of ptosis, to check for any facial weakness or to check for the motion of the eye. And then to proceed with the gait as part of the cerebellar exam, and then to note for any signs of meningeal signs and check for anal tone. Okay, next. So this is the meningeal sign and Gower sign. Meningeal sign seen in meningitis and Gower sign seen in Duchenne muscular dystrophy and any other causes. Next. Okay, these are the differences between the upper motor neuron lesion and lower motor neuron lesion based on the PE as well as investigation. Okay, next. Okay, now for the investigation.
Apa beza
Yes.
dia?
Oh, basically, okay. Okay, for the
very important clinical finding.
okay, for the upper motor neuron lesion, it's it's based on the lesion. For the muscle weakness, for the upper motor neuron, it can be seen as quadriplegic, hemiplegic, dysplegic, or paraplegic. However, in lower motor neuron lesion, it can be proximal or distal weakness. And then for the muscle tone, it can be hypotonia in lower motor neuron lesion. And then fasciculation is absent in upper motor neuron lesion and present in lower motor neuron lesion. And in upper motor neuron lesion, there is hyperreflexia. However, in lower motor neuron, it's hypo or no reflex. And then for the test, we can do the electromyography that can see the nerve conduction activity, and it's normal in upper motor neuron. However, it's abnormal in lower motor neuron lesion. Okay. Next, for the investigation, since it is more specific on the suspicion, which based on the clinical finding, we have to make sure what to see what's the relevant investigation. Okay, so for the lab study, we can do full blood count to see if there is any signs of infection, for serum creatine kinase that is elevated in inflammatory myopathy, and then serum electrolyte to exclude metabolic myopathy, and lumbar puncture to rule out infection. And then imaging study like MRI of the spine is done to rule out spine pathology, and other diagnostic tests like nerve conduction studies that is essential in neuropathy and neuromuscular junction problem, and electromyography. Okay, next. Okay, for the management, usually in a child presenting with weakness, we have to first focus on the child's airway, breathing, and circulation, because there are causes of weakness that can cause respiratory insufficiency. So therefore, we have to assess the respiratory effort, also the airway, as well as pulse asymmetry. And then we proceed with the specific management based on the causes, like the brain tumor, which is to refer the neurosurgical team, infection to start antibiotic, and so on. Okay, and then we should also note the needs for physical therapy and mobility aids. Next. Okay, this is an algorithm of how to approach a child with acute facet paralysis. So acute facet paralysis, which means that the child has weakness, paralysis, and then facet, which is hypotonia. So in all cases of acute facet paralysis, we have to pay close attention, because this can caused by many causes, including poliovirus infection. Therefore, what to do is in all cases of acute facet paralysis in children less than 15 years old, they should be reported, and also to send the stools for specimen investigation. The lab study, and then we should also follow up the patient until the final diagnosis. Okay, next. I think this is the references and the end of my slide. For the case of for the case complained earlier, you can read more on the report, which is on the last link about Guillain-Barré syndrome. Okay, I think that's all. Thank you.
Okay. Okay. Important to realize upper motor and lower motor or the one in muscle. The treatment solely. Okay, next.
Okay, Assalamualaikum.
Tadi apa Umi Ifah tadi ya?
Ya,
Umi
doktor.
Ifah.
Umi Ifah Zakiah.
Zakiah.
Nama siapa ni? Siapa? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 18, 19. Panjang ni macam ni seborang ni tu. Okay, next. Sekarang you are 3 nama sekarang ya. Non, Idana, Nabila, Umi, Ifah, Zakia, Noain,
Anis Najiha.
Anis Nur. 3 sekarang 3 nama. Sekarang memang tendensi 3 nama
Sekarang trend sekarang.
Ya.
Mm.
Tengoklah nanti bila sampai satu level bila kita orang kena si banyak borang you katanya kenapa lah panjang nama. Yalah. Ada 10 nama. Okey ha.
Okay, I proceed. So today I will present about the child who has diarrhea. My name is Norain Anis Najiha with matric number 8182240. Next. Okay, so the chief complaints mainly comes with loose stool, where a 5 years old Malay boy with no non-medical illness was presented with a chief complaint of loose stool for 1 day duration. Okay, let's see the definition. According to the WHO, diarrhea is the passage of 3 or more loose stool or liquid individual. So diarrhea can be divided into acute and chronic diarrhea depending on the durations of the onset, where acute diarrhea is mainly less than 14 days and chronic diarrhea is 14 days and above. Next. So for the differential diagnosis, this is the common differential diagnosis that can be divided into acute and chronic diarrhea. So for the infants, the most common acute diarrhea is gastroenteritis, where the most commonly is virus such as rotavirus, and followed by the bacteria such as salmonella and also shigella, and then lastly by the protozoa. And then other differential diagnosis can be systemic infection, antibiotic associated, and overfeeding. As for the chronic diarrhea for the infants, it can be due to the cause meat protein allergy, chronic non-specific diarrhea or infancy that can also call toddler diarrhea, and also post-enteritis syndrome and excessive fruit juice ingestion. As for the child, the most common cause of diarrhea is also viral gastroenteritis, followed by food poisoning, systemic infection, and also antibiotic associated. And for the child, can be due to the lactose intolerance, post-enteritis syndromes, IBS, and also giardiasis. Next. Okay, so for the history taking, for the back.
Balik. Ke yang causes. Okay.
Okay, so for the history for acute, as for the diarrhea, we need to ask the onset of the diarrhea, where it occur, and then specifically what the last meal he was taken, and then if it occurs after drinking milk, because it might be due to the lactose intolerance. And then we need to ask the number of episodes per day, because we know that diarrhea can be classified if it's more than 3 days or more than the individual basis. And then the amount to quantify the hydration status of this patient, and then if there is presence of blood or mucus that might be due to the Shigella or Salmonella, and then we need to ask about the normal bowel habit, and is this the first episodes of the occurrence that might suggest the acute onset. And then we need to ask about the related question, whether the patients have a recent history of outside food that might suggest AGE in this patient, and then if there presence of the recent change of formula milk that might be the causes of the diarrhea, and then if there are any presence of the sick contact or anyone with the symptoms with the same symptoms that might be due to the food poisoning, and then is there any recent traveling that might be due to the infectious diarrhea such as giardiasis. And then we need to ask about the associated symptoms such as vomiting, fever, and also abdominal distension. We need to ask about the abdominal pain or increase of flatus that might suggest that this patient is actually having a lactose intolerance. And then we need to ask about the reduced oral intake. We need specifically to ask about the hydration status of the patient, because we know that diarrhea is commonly associated with the dehydration. So this might be important to guide us in a management later on. And then we need to ask about the weight loss and ratios. Next. So this is a Bristol stool chart that might guide us in history taking. Like we can show this to the parents and ask the parents if he saw the diarrhea, like which types of the diarrhea that the her child is currently facing. Next. Okay, other history, you need to ask of the patients about the immunocompromised, and then is there any drug or allergy history, like using of laxative or antibiotic, because there is antibiotic associated diarrhea, and then allergy immunization history, or is there any presence of the additional vaccine like rotavirus that might be protective against the rotavirus causing acute gastroenteritis. And then we need to ask about the nutritional history, the normal diet intake. We need to ask the parents regarding the milk water hygienes, because this might be the causes of the diarrhea. And then we need to ask about the family history. Is there anyone with the sick complaint? And then the water sources, because there might be suggestive of the infective diarrhea like giardiasis and also E. coli that comes from the water sources. Next. Okay, for the physical examination for the acute diarrhea is mainly to assess the hydration level of the child, because most patients come for diarrhea having dehydration level. So we need to check for if the patient is less active, irritable, and ability to drink. Is there presence of the sunken eye, sunken fontanelle? And then we need to check for the vital signs, temperature, and also abdominal examination, like tenderness or any presence of distension. And this is the picture showing that the child having severe dehydration, where there is presence of the sunken fontanelle, sunken eyes, and lack of tears when crying, and so on. So next. Okay, so this is a table that classify the dehydration status into mild, moderate, and severe. So like you can see if the patient is having altered mental status, increased heart rate, and then you can see that there is prolonged capillary refill time, and the presence of the sunken eye, sunken fontanelle, and she was crying without tears. This might suggest of the severe dehydrations, which needs immediate management. Okay, next. Okay, so for the history on a chronic diarrhea, we need to ask about the onset of the diarrhea, whether it's congenital or not, because if a congenital, then this might suggest of the sodium absorptions in the patients. And then if there's abrupt onset, because it might suggest of the infectious diarrhea, and whether it's gradual and with introduction of it, because this might give an idea this is because of the celiac disease. And then we need to ask about the characteristics of the diarrhea, whether it's a bloody diarrhea or a light tin color that might suggest celiac disease. And then we need to ask about the associated symptoms like abdominal pain, flatulence, and loss of weight. And the complications of diarrhea is mainly malnutrition. So you need to ask regarding malnutrition symptoms like lethargy, irritability, brittleness, and frequent infections. And also we still need to assess the dehydration status if there are presence of the sunken eyes, dry lips, and reduced urine output. Other than that, we need to ask about the past medical history that might cause the diarrhea, like hypothyroidism and IBD. And then you can ask about the past therapeutic interventions, such as the diarrhea might be because of the drug side effects, and also prolonged antibiotic, because we know that antibiotic can also cause the diarrhea. And then family history, if there presence of the IBD or celiac disease in the family, that might suggest that the child also have the similar symptoms due to IBD and celiac disease. And then social history, if there presence of the water supply, and then any recent traveling. Okay, next, physical examination for a chronic. So for the general examination, you need to find out about the evidence of malnutrition, because we know that malnutrition is the most common complications of diarrhea. So like you need to ask if there are presence of the severe malnutrition like marasmus. So you need to check for the muscle bulk. You can like measure the mid-arm circumference for the muscle bulk, and then you need to check for the subcutaneous fat by measuring the tricep skin fold thickness, and also check for the hydration status, evidence of nutritional deficiency, and also check for the extra intestinal signs for the IBD, like oral lesion, uveitis, erythema nodosum, and pyoderma gangrenosum, which is the large ulcer commonly at the leg. And then we need to check for the anthropometric growth chart, just in case the child having a failure to thrive due to dehydration just now. And then check for the vital signs like tachycardia, tachypnea that might suggest that this child have severely dehydrated. And then is there presence of the abdominal distension, tenderness, and also bowel mass. Next, for the investigation. For the investigation can be divided into blood investigation, stool investigation, imaging, and others. So for the blood investigation, you need to check for the blood count just in case of anemia in chronic disease, and then renal profile that you might suspect that child will have a high urea and creatinine due to dehydration. And then liver function test that the child might have hypoalbuminemia in malnutrition, ESR and CRP that will be raised if there is presence of the inflammations. And then if you suspect the patient was in shock, then you might do ABG to check for the metabolic acidosis. And then if the child has a poor oral intake, that you might do a random blood sugar in case of suspecting hypoglycemia. And then stool investigation, you need to check stool microscopy examination to check for the any presence of blood in case of Shigella and Salmonella. And then stool blood culture and sensitivity, and stool electrolyte content to check whether this due to the osmotic or secretory diarrhea. And then you can check for the fecal calprotectin if you suspect IBD and we expect it to be high in IBD. And then for imaging, you need to check contrast study or CT scan, abdomen or MRI if you suspect there is presence of the small bowel, and also stricture in case of IBD. And then others, like you can do also colonoscopy and biopsy. Next. Okay, as for the management of diarrhea is mainly depending on the dehydration status of the child, whether the child is severely dehydrated or just mild or moderate. So if just mild or moderate, you might go for a plan A and plan B, where you can give fluid and treat the diarrhea at home, or just give it and then food for some dehydration. But if the patient was severely dehydrated, then you might give fluid for severe dehydration and provide food as soon as the child can tolerate. So the mother can give extra fluid by breastfeed frequently and longer than usual. You might also suggest the mother to use oral dehydration solutions, or if the patient is severely dehydrated, then you can give IV fluid therapy. You need to ask the mother to continue feed the child and know when to return to the hospital, like when the child are having drink poorly or not able to drink, become sicker or develop fever, and also if the child has blood in the stool. And as for the pharmacological agents for diarrhea, we can use antimicrobial in case if we suspect the patients have bacteria causes diarrhea, and also zinc supplementations. So generally, actually the management of the acute diarrhea is basically to give the fluid, to replenish the fluid loss in the patients. And then next is the management of the chronic diarrhea. So first, we need to give the initial resuscitations with IV fluid. You crack any fluid and electrolyte abnormality. So if there is presence of the hypoglycemia, and you prevent the hypothermia. And then to identify and treat underlying causes, because chronic diarrhea might be due to some things that chronic illness like celiac disease or IBD, something like that. And then nutritional assessment and rehabilitation, like for micronutrition deficiency, you can give micronutrient supplementations. And if the child is having lactose intolerance, then you can suggest to use lactose-free formula milk. And then serial monitoring of serum electrolyte in early stage of nutritional recovery. Next. So that's all from me. Thank you.
Diarrhea sebenarnya topik dia besar. Tapi kalau let you all tak buat, kalau you don't give you a guideline, ke 1 jam you present. Half you sleeping already. Okay, anything? Okay, tak ada. Last kali group pukul 4 nanti And group, which group is it?
Ya, Doktor. Group Dato.
Group apa? Syarah guru, you group bukan?
Group A.
Ha? Group mana?
Group A.
Group A.
Group
Ha.
Dato.
Berapa kali dah ambil dengan I?
Tak pernah lagi, doktor.
First time ke second time lah?
BSC tak pernah lagi. Hari itu prosedur.
Biasa tak pernah lagi. So, okay. Biasa first, tak apalah. Second time, biasanya yang tu, yang tension tu, I dah expected you dah pandai. First time tengok macam mana. Year 3 dah ambil dah? Pernah ambil year 3 dulu? Year 3 dulu pernah ambil tak?
Year 3 pernah. Pernah.
Ambil tahulah. Okey, okey, ada jumpa lagi.